First of all, I just want to thank you all for being here tonight because you made a choice to be here and to learn. So thank you. This is a topic that's super close to my heart. As Mike mentioned, I'm a hepatologist. I did all of my training in internal medicine and then liver disease, liver transplant. And I've been focused specifically on fatty liver disease for the past decade. And been doing a lot with clinical research in the field. So we're going to talk today. I mean, what I want you to take away from today is just some key points about what fatty liver is, what you need to be asking your clinician, and whether or not, either you or others in your family may need to get tested. So, all right, so fatty liver is the most common liver disease in the US. It can be caused either by alcohol, which is historically what, in the 80s and 90s, we used to think if a patient had liver disease in general, that they were an alcoholic or that they were engaged in other high-risk behavior. Now we know that much of fatty liver is actually not associated with alcohol. And the term that was used just 10 years ago when I started in this field was non-alcoholic fatty liver disease. So the term itself was called non-alcoholic fatty liver disease. So it had fatty liver in it, and it had not related to alcohol. So it was kind of stigmatizing for patients, right? Like, why are you bringing up alcohol? I don't drink. So because of that, many stakeholders, including patients, came together and wanted to change the name of the disease. So very recently, in the past couple of years, the disease has been changed to MASLD, metabolic dysfunction associated steatotic liver disease. It's a mouthful, but basically it means that fat in the liver is due to metabolic dysfunction, and we'll talk a little bit about what that means. You only have to have more than 5% fat in your liver to have a diagnosis of fatty liver, and most commonly, patients will come to us not even feeling any symptoms, as Mike said. I think the danger in this disease is that it's asymptomatic, and they will go to the ER, or they'll go to their primary care physician for something else, have an image that shows that their liver has fat in it, and then they'll come to us and say, how did this happen? When we talk about alcohol use, there's been a lot in the press recently about, the post-COVID rise in alcohol consumption, particularly amongst women, and the rise in alcohol-related liver disease. It is on the rise. So when we talk about how much we drink, we need to be all talking in the same language. So what is a standard drink? When your doctor asks you how much do you drink? A standard drink is defined as 12 ounces of beer, 5 ounces of wine, or 1.5 ounces of hard liquor. It's interesting because I'm sure you all have your stories, but I didn't recognize until I started training that the tall boy beer is actually 24 ounces, so it's 2 beers. So just kind of understanding and quantifying how much alcohol is in what we're drinking. And I can tell you for sure from personal experience that a pour of wine at a normal restaurant is not 5 ounces because I drink. So who should get checked? Those of you who are here, how many of you had the fiber scan today? Okay, and more going to get it later? Okay, perfect. You may have come because you're worried about your risk. What I want you to take away today is that anybody with type 2 diabetes needs to get their liver checked. They need to be checked for fatty liver, and they need to be checked for the progressive form of fatty liver disease called MASH, and that's what we're going to be focusing on tonight. If you don't have diabetes, but you have some other risk factors, you should also be a little bit concerned and want to get your liver checked. If you have 2 metabolic syndrome risk factors, what does that mean? You may have high blood pressure. You may have some abnormalities in your cholesterol panel, either high triglycerides or low good cholesterol or HDL. You may be carrying some extra weight, have a BMI over 30, or you may have something that we call insulin resistance. So your hemoglobin A1C, it's a lab test, maybe 5.7 or above, and or your doctor may tell you have abnormal fasting glucose. All of these are risk factors, and you really need to kind of talk to your doctor about, do I need to get further testing, not only for you, but also for your family members. If you have imaging, you've gone to the doctor and you have imaging showing liver fat, It is good to get further testing. If you've also been told, hey, your liver tests have been abnormal over years, but no one's really told you why, again, probably a reason to get tested. And this is a take-home point for me. Family history is often overlooked. Anyone who has a family history, a first-degree relative, mother, father, siblings who have cirrhosis, they really should be staged for their liver disease. And here's what we focus on in this field. We don't focus on MASLD. MASLD is it's the big umbrella term. So millions of people, 1 out of 3 people in America, adults in America, have MASLD, okay? So a third of us in this room have MASLD. MASH is the more progressive form of the disease. What I like to say, it's fat with inflammation. And as you can see on this second picture up here, it's actually very specific. If we took a biopsy of your liver, we can see very specific findings on the biopsy that show the liver looks very angry, right? So there's inflammation, there's cell injury, and what happens as a result in the liver when there's inflammation is that the liver puts down scar tissue. And scarring, in general, is not good in the liver when it accumulates over time. We have a normal response in the liver to put down scarring, actually. So, for example, in your 20s, you go out and maybe you had 1 or 2 more drinks than you needed to have, your liver actually recovered on its own. It's a normal response. But when the liver is consistently injured over time, the liver doesn't have enough time to recover and the scarring accumulates. At the end of the day, what we're trying to avoid is this picture all the way on the right. So we're trying to avoid something called cirrhosis. How many of you have heard of cirrhosis? So this is what we call F4 disease or stage 4 scarring in the liver. It is basically the end stage of scarring. And what I have tried very hard to do and move towards in my practice is to find patients before they are closer to cirrhosis so that we can actually do something about it. And the concepts of injury are pretty simple. If you're having more damage and injury than you're having healing, you're going to have progression, right? If the damage and healing are equivocal, so you're having damage but your liver is getting some relief, there's no progression and you have stable disease over time. And then what we really want to see is that we're allowing the liver more healing time, and we're allowing for actually improvement of disease. So this is a dynamic process. You can actually move from one stage of scarring to the next. However, once you have cirrhosis, that becomes much more difficult. So that is also why we try to prevent it. How common is it? Like I said, in the US, MASLD prevalence is, it says here, globally it's about 25%. I think we're living in Texas. This is much higher. So I actually live 3 hours south of here in the Rio Grande Valley. And I can tell you from anecdotal experience, just my experience in clinic and seeing patients, that this is definitely closer to 60 to 70%. So San Antonio is not that different from the Valley. Very similar where, prevalence is much higher in Texas. NASH, the progressive form or MASH, is less common, but we also see that in places like Texas, that prevalence is higher, and I'll show you in a slide. Now, this is why I say focus on patients with diabetes, right? Because the prevalence, how many people actually suffer from this, increases significantly. And so here you can see that in the US, that prevalence rises to 50%. So if I talk to a physician who focuses on diabetes and he or she has 10 patients sitting in their office, I would argue that in Texas, 8 out of 10 of them have fatty liver. Okay, so the majority of patients with diabetes have fatty liver. Here you can also see that MASH prevalence is higher as well. So we're just going to see it more commonly, and these patients are really the ones that we want to focus on. This was a study done by my mentor, Dr. Harrison. He's from San Antonio. He actually did a study in the VA here, and he looked at all people who were coming to the VA who were getting their screening colonoscopy, right, looking for colon cancer. And he asked them, do you want to look at your liver health? They didn't know anything about their liver, but he asked them, do you want to look? And what he found in doing further testing, so he did labs, he did imaging, he did biopsies of their livers, he actually found that in that patient population, fatty liver affected 40% of them, right? So 40% of people had fatty liver, and NASH or MASH affected 15% of them. So these are people who had no idea that they had liver disease. So it tells you, this is your city. This is a study that was done right here. So these numbers are higher than what we expected. And this shows you further that if you look at specific populations, right? So we're all not the same. If you look at folks who are Latino or Hispanic, 55% of those patients had fatty liver, and 1 out of 4 of them had MASH. So if you are Hispanic, you have an increased risk of having more advanced liver disease and having MASH. If you are diabetic, again, this just goes back to what we talked about, increased risk of having fatty liver disease, increased risk of having MASH, and the most enriched population. So if you are a Hispanic female over the age of 50 and you have diabetes, every single one of those patients in your family, for example, should be checked for MASH. Because in this cohort of patients here in San Antonio, 92% of them had fatty liver and 1 out of 2 had MASH, okay? So that's really the take-home point for me here is, if you have diabetes, if you are enriched, right, if you have these risk factors, you really need to start thinking about it, not just for yourself, but also for your family. Why does this matter? Is because MASLD is the most common cause of cirrhosis. There are tons of other causes of liver disease, but what we are, what we tend to focus on are the things that are common. And, this is not going anywhere, as obesity and diabetes rates are also increasing, so are rates of MASLD. MASH is also the leading cause of transplant in women, as you can see here, and alcohol is also on the rise, as we talked about, so that's also important. But MASH is going to continue to place a burden on the healthcare system and also on people's lives as they progress to cirrhosis and potentially develop liver cancer. And here we live in Texas. Texas is the state that has the highest what we say incidence of hepatocellular carcinoma, which is liver cancer. So MASH is related to hepatocellular carcinoma, and in the valley, in the Rio Grande Valley, we actually, within the state of Texas, have the even highest incidence of liver cancer cases there. So again, there is, it's a call to action to really identify disease early so that we can, if patients develop cancer, we can catch it early. And what I said earlier, the burden of this disease, if we model this out in these fancy models to look what it's going to look like in 2030, we're talking about 101 million cases of MASLD, 27 million Americans impacted by MASH, and those with more advanced disease. So when I say F3, F4 disease, that just means that there's more scarring in the liver. These populations these are the people that we care about, the people that have MASH and more scarring in the liver. Look at the increase, 160% increase by 2030, and in cirrhosis as well. So what does this lead to? This leads to more cases of liver-related death. This causes more cases of liver cancer. And once you develop cirrhosis, things can go very wrong and you start to develop symptoms from cirrhosis, which is, again, what we want to try to avoid. So that's all great. I threw a lot of information at you. So what do you want to do now? I think the take-home point is to know your risk factors. Do you have risk factors? And to also know your risk scores. So many of you had the FibroScan already, so you're way ahead of the game. But I think something that I want you to take home as well, to talk to your family about, or to even talk to your doctor about, is knowing what your FIB-4 score is. Okay, this is a super simple score. If you do your blood work every 6 months, you have this score, because all it uses are a simple few blood tests that you're already getting. Why are we even talking today? You know, we're talking today because over the past 10 years, the management of fatty liver has changed, and we are so much more focused on screening. When I was in training 10 years ago, we didn't have screening algorithms for fatty liver. We didn't know necessarily what to do. So now in many guidance documents from these societies, so the clinical endocrinology, the GI society, our liver society, they're all telling us that if you have risk factors, your physicians should be screening you and risk stratifying you, putting you into a bucket of risk based on these different tools that they have. So what the FIB-4 is, basically, here you can see on the left, if you have these risk factors for fatty liver, your physician should be calculating a FIB-4. And if the FIB-4 is high risk or indeterminate risk, then you should be getting either a FibroScan, which is what you may have gotten today, or you can do another blood test called an ELF. And based on those scores, you are then put into a risk bucket. And then we determine, as your clinician, what to do next. What are we going to advise? So really important, I think, for patients to also have a little bit of a sense of ownership, right? That you can ask your physician, what is my FIB-4? You don't have to wait for them to tell you about your liver status. You can ask them that question. And here's the FIB-4. It's a simple calculator. It uses age. Your AST and your ALT are just your liver enzymes. So these are markers of injury in the liver. And then your platelet count, which you should be getting at least once a year. And you can basically plug those into the calculator. And as I said, above a 1.3, you need to be asking your physician about that. Many of you had the FibroScan today, so this is a great tool. I kind of call it one of the new vital signs of the liver. So you get your blood pressure done. You should also be getting a FibroScan anytime you come to a liver specialist. And the FibroScan looks at two biomarkers. It looks at fat content in the liver and the stiffness of the liver. So those of you who had it, when you were lying flat and you were feeling that kind of thump on your liver, right? There was a wave that was being propagated to the liver to look at these two measurements. And so this test is actually better than an ultrasound to capture fat content in the liver. And stiffness basically signals or means that we may have scarring in the liver. So it's a great tool to tell us, Houston, we have a problem, potentially have a problem, or that that you're low risk and you can go back to your primary care physician. And so if you have a healthy liver, the wave is going to go very slow, as you can see here. And if your liver has more scarring, or fibrosis is what we call it, then the stiffness will be higher. Really above an 8.5 is when we start to want to do further testing. And this is, the range goes all the way up to 75. And here again, this just shows what we call attenuation rate, and that correlates to fat in the liver. So if you have a low cap, below 260, we typically say, there's not much fat in the liver. Above a 260, we quantify, we can quantify fat in the liver. So once you have a diagnosis of MASLD, it depends on where you look for guidance, but in general, the treatment is really centered around lifestyle modification. So, the goal is to make sure that, Mike had mentioned earlier, that we're cutting out foods that are injurious to the liver. So anything that is highly processed, bad for your liver. Foods that have a lot of high fructose corn syrup, bad for your liver. This is like Coke, right? When you're drinking Coke, that's really bad, not good for your liver. And sugar content in general, right? You want to try to decrease with fatty liver. If you look at any of the societies, they recommend the Mediterranean diet. Many of you may know about this diet. But we have to be also culturally sensitive, right? Not everyone's going to go and start the Mediterranean diet. So you do what you can in small amounts with the diet that you normally have. But at the end of the day, really trying to eat higher quality foods and cutting out highly processed foods. When you go into the supermarket, for example, what are highly processed foods? It's basically everything that is within the aisles of the grocery store. What are not highly processed foods are everything around the outer parts of the grocery store, right? So these are real foods. And I also say minimize alcohol intake. I actually counsel patients with MASH to not drink. And then exercise, right? How many of you exercise? Yeah, Naeem. Dr. El-Khoury's here. Movement, it really, all of the data now suggests, any movement is better than no movement. So you have to do what you can, but if that means you're gonna go out and you're gonna walk the dog for 20 minutes, or that you're gonna go to the gym and you're gonna do a light amount of weights, you have to tailor it to you, but any movement is better than no movement. Sedentary lifestyle is the worst possible thing you can do when you have diabetes and when you have fatty liver. So that's really the take-home point. Here it says moderate physical activity for 30 to 60 minutes, at least 3 to 5 days per week. Resistance training is important, especially for women. Once we get above the age of 35, we start to lose muscle mass. So we should be doing weights. We should be doing light weights. And we want to reduce stress as much as possible. Exercise does that. And we want to sleep well, because when we don't sleep, our cortisol levels rise, and that actually causes more insulin resistance and does more harm. For your physicians, people that you are seeing, they are also going to be having goals for managing MASH, and they want to be focusing on controlling your risk factors. So if you go to your doctor and they tell you, hey, your A1C is 8 and you have diabetes, you're going to say, well, hey doc, I'm doing all the right things on my end. Maybe we need to optimize my diabetes regimen, right? Because it's super important. All of these things drive the disease forward, and so we want to be actually controlling those risk factors. And weight loss really is, lifestyle modification and the resulting weight loss is really what moves the needle in MASLD. So if you can lose, 10% of your total body weight, you're actually moving the needle on fibrosis. Remember scarring in the liver. So you can move the needle to go regress from one stage to the next. But really only if you lose, more than 5% of your total body weight, you are impacting the disease. But the goal is more than 10%. More than 10% of your total body weight. And I think that this is so important because, again, when I was training, we didn't have anything. What we would do is you would come see us and we'd use the tools that we had. We didn't even have FibroScan at that time. It was like in the research department, we couldn't even access the FibroScan 10 years ago. And basically we would say, we would talk you through the lifestyle modification, put you on a plan, and then see you again in 6 months and check your liver tests. Now, in 2026, we actually have 2 drugs that are approved by the FDA, specifically for patients with MASH and scarring in their liver. So if you are diagnosed, and you know, it's an unfortunate thing that you have to deal with, and you're diagnosed with MASH with scarring in your liver, your doctor actually does have tools in their back pocket that they can use. So these are two drugs, Resdifra and Wegovy. And in most cases, no biopsy is required. So that's a big deal, because we actually in clinical trials had to do biopsies on patients. But now, you know, for patients to get access to these drugs, biopsy is not typically required. And so, again, once you kind of understand where you lie in the risk stratification, please ask your doctor about this. And so putting it all together, again, know your risks, get staged early. Treatment options are available now to us in 2026. Do not forget about lifestyle modification, because you can really move the needle. There's no magic pill. GLP-1s, you know, everything that we talk about, there's no magic pill. You have to do it with lifestyle modification. And I would like to say, personally, I feel so positive about the future for patients living with MASH, because we have these currently approved drugs, and there are many in the pipeline, and there's a lot of effort and money that's being put into learning more about this disease. So I feel really confident and really optimistic for our patients. And I'd just like to thank our team at Pinnacle Clinical Research. We're here in town locally. We have a wonderful team. Our patients are wonderful. And Dr. Harrison, who is the founder of Pinnacle Clinical Research, dedicated his entire life to the study of fatty liver disease and took us so far. We tragically lost him in 2024, but everything that we do is in his honor. All right. Thank you.